In this first lecture, we will concentrate on providing you with a general introduction to varying imaging techniques. In today's lecture and the following practicals, we will focus on the learning objectives which you will see here highlighted in red. So the ability to determine and differentiate between the different imaging modalities, X-ray, ultrasound, MRI, CT and bone scans. For you to start to develop and distinguish between which would be the most appropriate imaging modality and views needed for visualization of specific pathologies. To identify and appraise indications and contraindications for the use of varying diagnostic imaging modalities in the foot and ankle. And to consider the legal and ethical and medical ramifications of the use of different imaging techniques. So when we use the term diagnostic imaging, what do we actually mean? Well, diagnostic imaging is a generic term which covers a whole broad spectrum of different imaging techniques, including radiography or conventional radiography, it can be referred to, or X-rays, which you may be more familiar with, ultrasound imaging, CT scan, so computed tomography, bone DEXA scan, so bone densitometry, MRIs, or nuclear medicine. Imaging techniques contribute to our understanding of the pathophysiology of underlying disease processes. They may assist with a diagnosis and further help to work out which treatment may be more appropriate based on the underlying injury or pathological condition. An accurate diagnosis is always dependent on the combination of imaging with history and clinical examination. So we should really have a good idea of what our potential differential diagnoses are, and we use imaging very often to either confirm or refute our clinical suspicion. So it's really important that you understand that imaging is used to assist a diagnosis from all of the relevant information we have from our history taking and our examination techniques. We should never use imaging as a blanket and a fishing expedition to try and assist with working out what's going on with a patient. So why is it important for you as a podiatrist to have such a good underlying understanding of imaging? Well, it's really important because podiatrists have imaging rights in Australia. As a registered podiatrist, you'll be able to refer patients under the Medicare plan for plain X-rays of the foot, leg, knee and femur, and ultrasound examinations of soft tissue conditions of the foot. You will also be able to order CT, MRI and other imaging techniques, but please be aware that these would not be covered under Medicare if a podiatrist refers, and often these imaging techniques can be very expensive. So if ever you are making a referral which wouldn't be covered under Medicare, it's absolutely essential that your patient understands that they will have this expense and that you probably document that in your notes to say that you have had that discussion. So this slide summarises the imaging items for Medicare rebate by podiatrists. What you can see is in terms of plain films, so plain X-rays, you can see that you're able to request a number of different imaging areas, including the foot, ankle, leg, knee or femur. In terms of ultrasound, you will see that in terms of how high up in the lower limb you are able to go, it's much more confined to the ankle, hindfoot, mid or forefoot. However, assessment of a mass associated with the skin or subcutaneous structures would be covered. So it's interesting to note that as a podiatrist you will be able to take an X-ray of the femur but not of the hip. It's important as a podiatrist that you also understand just what the financial implication of imaging that you may be requesting is. So here you can see that typically you will see that the fee for a plain X-ray would be 43.40 and the Medicare rebate benefit would be 75%. This means that there will be some out-of-pocket expenses for patients. When you have a look at ultrasound imaging, you will see that because the overall cost of the imaging is more, there will be a potential increase in the out-of-pocket expense for patients. So as well as considering the financial implications, as podiatrists we will also need to consider the ethical considerations of using imaging. And as a general rule of thumb, the benefit to obtaining the imaging must outweigh the risk, particularly of tissue damage from the technique to the patient. So we must remember that imaging techniques including X-ray and CT and fluoroscopy all will expose the patients to radiation, which theoretically has risks in terms of increased risk of malignancies. In terms of nuclear imaging, there will also be exposure of the patient to radioisotopes. So it's really important that we understand that there needs to be this balancing act of risk versus benefit. We also need to consider that when we order imaging, that it really would need to influence the outcome for the patient or potentially alter the treatment that would be proposed. For example, if we have a patient with advanced osteoarthritic changes within a joint, we simply would not order an X-ray to just confirm our clinical suspicion. However, if we were uncertain and it would perhaps we were uncertain of the level and how responsive the joint may be to mechanical based therapy or whether surgery might be most appropriate, then it might be warranted to order an X-ray of the arthritic joint in that case. So we need to remember generally the cost of any imaging technique, the financial implication and potential out-of-pocket expenses to patients. We really need to consider the radiation exposure, and one of the principles that you will need to understand is ALARA, and we will want to keep exposure as low as reasonably achievable. So that's what ALARA stands for, as low as reasonably achievable. Now I apologise for this slightly busy looking slide. However, this is a really nice table in a review article by Eileen Tan in the Best Practice Research in Clinical Rheumatology. And in this table, Eileen provides a really nice summary of the benefits of imaging, the potential risks, and also the indications of where one imaging modality may be better than another. So CR stands for conventional radiography, so X-rays, MRI for magnetic resonance imaging, US for ultrasound, and CT for computed tomography. And what we can see is in terms of the costs, we can see that X-rays are relatively inexpensive, as is ultrasound. In terms of exposure to ionising radiation, you will see, and it's important that you understand, that MRI and ultrasound do not expose patients to radiation, and it's really important that you understand that, whereas X-rays and CT do. And we'll talk about the different levels of radiation exposure in a couple of minutes. In terms of the types of tissues that can be seen, what you will see is that when we get to our typical soft tissues, so tendons, tendon sheaths, ligaments, that you will see that with an X-ray, none of those structures are visible. Whereas we can get good to excellent resolution of those structures using MRI or ultrasound. In terms of the ability to detect early changes, particularly erosions, which we commonly see in patients with inflammatory joint diseases, you will see that erosions really are not seen at an early stage on an X-ray, and it would be much more appropriate to use ultrasound or an MRI. It's important to recognise that one disadvantage of ultrasound is that it is considered to be dependent very much on the skill and expertise of the operator, so the person taking the scan. And you will see that that's the case with just ultrasound. All of the other imaging modalities are considered to be not operator dependent. In terms of radiation exposure, it's important to understand that any type of ionising radiation that's imparted to or absorbed by the human body has the potential to cause harm to health. To look at the biological effects, we must know or have an estimate of how much energy is deposited per unit of mass of the part of the body being imaged or the body as a whole with which the radiation is interacting. When we look at radiation levels, it's important to get confused due to differences in units in which radiation is expressed or the different types of radiation. Different types of radiation can have differing biological effects. For example, neutron, proton or alpha radiation can cause 5 to 20 times more harm than the same amount of absorbed dose of either beta or gamma radiation. The biological effects depends not only on the amount of absorbed dose, but also the intensity of the ionisation in the living cells caused by the different types of radiations. So, for example, different tissue types also have different sensitivities to radiation in their potential for biological damage. The ovaries, for example, are 20 times more sensitive to radiation than the skin. And this may explain for any of you that have had an X-ray as to why the radiographers will wear, kind of one of the lead-lined aprons to protect those more sensitive tissue structures. The international, so the SI unit of measure for absorbed dose is the grey, and it's given the symbol a big G and a little y. And this is defined as 1 joule of energy being deposited in 1 kilogram of mass. The old unit of measure for this was RAD, so RAD, and that stands for radiation absorbed dose. 1 gray corresponds to 1 joule of radiation deposited in 1 kilogram of matter. So to give you an idea, it would take around 320,000 joules of energy to boil 1 kilogram, so 1 litre of water. A uniform dose of 3 to 5 gray to the whole body would kill 50% of people exposed to it in 1 to 2 months. This is a large unit, so it's more common that we see this expressed as milligray, which is 1,000th of a gray and which is more commonly used. When you look around in this area, you may also see reference to the use of sieverts or millisieverts, as you will see in this table here. When we're thinking about radiation, we must remember that radiation is permanently present throughout the environment in the air, water, food and soil, and in living organisms. A large proportion of the average annual radiation dose received by people results from exposure to our natural environmental sources. So each member of the world's population is exposed to, on average, 2.4 millisieverts of ionisation radiation from natural sources. In some areas in different countries of the world, the natural radiation dose may be 5 to 10 times higher. Dose-dependent biological effects become measurable above 50 millisieverts, and a whole body dose of greater than 10 sieverts is universally lethal. The average radiation dose for a person in the UK is around 2.6 millisieverts per year. 2.2 millisieverts would come from exposure from natural sources within the environment, whereas typically 0.4 millisieverts would relate to radiation for medical exposure. In terms of different diagnostic investigations, typically they will involve doses between 0.02 millisieverts, which is that equivalent for a chest x-ray, up to 10 millisieverts for the CT of an abdomen, which means that a chest x-ray would equate to around 3 days of background radiation exposure, whereas a CT scan of the abdomen would be equivalent to exposure over around 4.5 years. So you can see that it needs to be duly considered in terms of the potential benefit of the radiation exposure, and this should outweigh the risk. So it's important that we keep at the forefront of our minds ALARA as low as reasonably achievable in terms of radiation exposure with the use of imaging. It may be that patients ask you to what extent the use of imaging may increase their risk of developing cancers. Well, work has been done to show that the increased risk of cancer on exposure to 1 millisievert of radiation is equivalent to 1 in 17,000. When referring people for imaging, it is important to determine if they may be occupationally exposed to radiation. These may be people that typically work in chemical plants, mining, and potentially within the medical environment. People that are occupationally exposed to ionising radiation would be monitored, and generally they would be required to wear a dose meter badge, which would be attached to their clothing at all times at work. These dose meters would be sent to a laboratory, typically at a monthly interval, where the total radiation exposure would be determined. In Australia, the average radiation worker receives a dose of 0.12 millisieverts per annum. In terms of giving you some appreciation of what the risk of obtaining cancer from 1 millisievert of radiation exposure is, it would be equivalent to the risk of getting cancer from smoking approximately 100 cigarettes. So keeping with the ALARA principle, and also having the recognition that different tissues are more susceptible to the biological effects of radiation exposure, and also different individuals, it's generally accepted that children are more susceptible to the biological effects of radiation than an adult would be. And particularly the younger the child, the higher the potential theoretical risk. And indeed, a study published in 2013 provided estimates of how many potential future cancers could be caused by the approximate use of CT scanning performed on children each year, which the authors found to be was approximately 4 million CT scans being performed on children each year. So it's important to know that this study didn't look at the actual number of cancers that developed, but it did provide an estimate and estimated that around 5,000 potential future malignancies could be attributed to the use of CT scanning in early childhood. So hopefully you have very firmly in your mind now that the use of imaging, the benefit should always be clearly outweighing the risk of exposure to ionisation radiation. And one such algorithm and guideline which has been developed to help clinicians determine whether the use of an X-ray is warranted and appropriate is the Ottawa Ankle Rule Charter. So these rules have been developed as a quick and reliable method of selecting which patients with ankle and foot injuries may need to have an X-ray to exclude the possibility of a fracture. And if we think about our ankle injury, these rules suggest that an X-ray of the ankle is necessary when the patient has pain over the medial or lateral malleolar zone and any one of the following findings. So there's bone tenderness on palpation of the distal 6 centimetres of the fibula, so the posterior tip of the lateral malleolus. There is bone tenderness on palpation of the distal 6 centimetres of the tibia, so the posterior tip of the medial malleolus. And there's inability to bear weight, so walk 4 steps, both immediately and after the injury and during your clinical examination. In terms of foot injury, the Ottawa Charter suggests that a foot X-ray is warranted with suspicion of a midfoot fracture if there is pain in the midfoot in any one of the following: bone tenderness at the 5th metatarsal base, bone tenderness at the navicular bone, and inability to bear weight immediately after the injury and when seen. These combined ankle and foot rules have been shown to have a very high sensitivity, 97.8%, at detection of fractures when used. So these are useful clinical guidelines which you would be expected to know to help guide you whether the use of an X-ray to exclude the possibility of a fracture is warranted. Now, at the end of this unit, we will expect you to be able to recognise different types of imaging modalities. And if you were shown a picture like this, would you be able to determine which different type of imaging modality was used? Would you be able to tell which was the different type of imaging modality? What the technique would specifically offer over any other? In what instances would the technique be warranted, and what would the limitations be? And I'm not going to answer this within the lecture, but we will pull up this slide again in the practical sessions, and I will go through telling you what specifically will identify the different imaging technique. So a major focus will be X-rays. However, we will go through the different imaging techniques. But plain film radiography, or X-ray, is the most commonly used modality and generally is considered to be the most cost-effective. It can be considered a gold standard for the use in rheumatology, particularly for hands and feet, and is fairly routine at the point of diagnosis. However, we will talk when we go through specific rheumatic conditions that really it's fairly insensitive to early joint changes in many of the diseases. With an X-ray, we would see a 2D representation. Therefore, we will often need to ask for different projections. Standardly, we may order 3 projections: the AP projection, lateral and lateral oblique are probably the most common for getting a full appraisal of the foot. What we recognise is that injuries are notorious for being very subtle on X-ray and almost invisible if just one projection is used, when they can be glaringly obvious in another view. So the use of multiple projections would allow us to see joints in more detail. So you won't be able to view all joints optimally in just one plane. So with only one projection, you must consider that generally you will miss things. And often we will find that X-rays would be used to precede some of the more sophisticated or costly imaging techniques. When we send a referral off for an X-ray, it is really essential that we provide enough clinical and supporting information to assist the imaging examination. We would need to be precise and identify the specific anatomy that's involved in the pathology to allow the radiographer to be able to determine the best positioning and view. We would need to offer some guidance on the potential differential diagnosis so that the radiographer can be cognizant of those and again perhaps ensure that they get sufficient detail on the key structures that may be involved. You'd need to provide some clinical notes so that perhaps an appropriate imaging sequence could be obtained. And you would need to specifically think about how you may approach this, particularly for a suspected ankle sprain stroke fracture, given what we've talked about with the Ottawa Charter.